Good morning, everyone, and thank you for joining us for day 2 of the Hearing Our Voices conference to discuss compassion and patient involvement in digital health, health technology, and care. My name is Julie Drury. I am the strategic lead for patient partnership at the Canadian Foundation for Healthcare Improvement. I'm also a bereaved mother, having lost my daughter Kate 5 years ago at the age of 8 after an extensive and complex lifelong healthcare journey. I'm joining you today from Ottawa, Ontario. I'd like to acknowledge that Ottawa is the traditional land and territory of the Algonquin and Anishinaabe people, and I'm so privileged to enjoy the beautiful environment of the Ottawa River, Gatineau Park, and the active lifestyle this part of Canada offers. As digital health, artificial intelligence, virtual care, and digital health information and data evolved, so must the relationships with patients and their healthcare providers, teams, and the organizations that offer their care. Concerns have been raised about equity and access to digital health and care, and ensuring patients and physicians and healthcare providers are supported to partner in care together. Our panel today is going to explore the challenges and barriers to digital health and will provide insight and expertise on potential drivers and solutions. I did ask our incredible panelists today to be bold with our conversation about how do we get there together, and to put forward some audacious and challenging topics or ideas for us to explore as a panel. We collectively pulled from our lived experience as people who have experienced the healthcare system intimately, as healthcare providers, and persons who develop and lead on policy. A few of us also did some crowdsourcing for ideas and suggestions from many of you, and several common themes for our conversation emerged. Though many patients are appreciative of their providers, they are frustrated by outdated communication modalities and digital processes. Most virtual care is happening by phone in a patient experience, and there are still many frustrations of patients who would like to access care through information, forms, and results by email or other virtual means. Patients have found it difficult to make interpersonal connections on the phone, even though it is convenient. They want to talk about the ownership of their health information and how they can more efficiently access it. Many patients are frustrated that they have to pay for their health records to transfer them or to access them. There are concerns amongst many about who gets left behind in these digital health and technology conversations. And even in our informal polling, thinking about who is not in the room, who is not available to answer these questions, and how important their voices and perspectives are. So now I'd like to introduce you to our panel. Dominik Nowak is a family physician at the faculty of the University of Toronto and chair of the TELUS Medical Advisory Council. Melissa Nyo is a caregiver and family support specialist who works at Holland Bloorview Children's Rehabilitation Hospital, and she is also a caregiver to a loved one in the healthcare system. PJ Moreau is a caregiver. He's also the founder of Patient Critical Co-op and has an expertise in digital health and virtual care. Laura Williams is a caregiver and patient advisor, and she is also the director of patient engagement at the University Health Network. And Alika Lafontaine is an anesthesiologist, associate medical director of Indigenous Health North Zone at Alberta Health Services. So panel, welcome to all of you, and thanks for being here this morning for this conversation. So I want to start us off with attacking some of those topics that came up in many of our previous conversations as a panel, and some of those themes that emerged from the crowdsourcing and the audacious and challenging ideas that we've discussed together. You know, one of the ones that came up, and Melissa and Dominik, maybe I'll pull you into this one right away, is around the fact that many Canadians are poorly served by the healthcare system already. And Dominik, in an article in Healthy Debate, you stated that the evidence is clear that neighborhoods with the fewest residents connected to a family doctor were also the ones with the most emergency visits for mental health crises, the lowest incomes, the highest rates of poverty, and the worst maternal health incomes. And without continuous relationships of healthcare teams, health disparities can worsen in those already impacted by the social determinants of health. So the healthcare system has forgotten and left behind people who are marginalized, racialized, and oppressed already. will advances in technology really help to improve these experiences, or will they exacerbate the issues that these people experience with the healthcare system? So Dominik, you get the pleasure of setting off our panel, and I welcome all of you to weigh in. But Dominik, tell us a bit more about that article you wrote in Healthy Debate and your experience as a healthcare provider in this space.
Yeah, absolutely. And I could talk for days about continuity, and I think there's another question specifically on continuity, but for this one, I'll just say two key things. So first, Julie, I think a lot of our role as doctors, as people who are involved in health policy, as kind of thought leaders in this space is allyship, right? And being a good ally could be one of the main parts of good that we can do for the healthcare system and for Canadians more broadly. And sometimes that means looking around and asking exactly the question that you asked earlier on when we were doing our introductions, looking at the tables that we're at and seeing who's not there, whose voice are we missing, and who needs to be here for us to actually forge ahead together in a way that's good for people at the end of the day and helps us drive forward kind of this kind and careful care that we want to be able to give to Canadians. So that's point number one, is allyship. And the second point based on that is, for many people in my practice, many folks will have a difference in the kind of care they can receive virtually versus even in person or in a kind of a private space or in my office. Because there is, this concept of the digital determinants of health as well. And things like internet access, technology proficiency. I think of a lot of my older adult patients who are very good with tech, and then some who really need that caregiver presence. And thinking through, when we do virtual visits, can we have a caregiver on as well? And for most of the time, actually, we can. It's not easy to do. And other times where folks just don't feel comfortable having a deeply personal conversation from their living room that's shared with other folks. So I think allyship is so important, looking at who's not there, and then looking at, with this shift towards digital health, who do we risk leaving behind, and how do we make that not happen?
I love that comment about digital determinants of health. I think that might have been the first time that I've heard that term. And as we're moving very much into the space of technology and leveraging technology, who are we leaving behind? And we talk very much about the social determinants of health, but those digital determinants of health. And Melissa, I know that you've had really personal lived experience with this, with that access to digital health and what that has looked like from a deeply personal point of view. Can you share that with us?
Absolutely. I just want to begin by saying, unfortunately, the foundations of how we provide healthcare are failing people who are already discriminated against systemically, and really that has come out in so many experiences that I've heard of and been through, who are part of the Black, Indigenous, people of color communities. And in my own experience, my grandmother had entered the hospital during the pandemic, and she received a cancer diagnosis, and we weren't allowed to see her. I had to advocate so hard and so much. I had to jump through so many hoops to just be able to get one caregiver beside her, and that was imperative because she's not technologically literate, and she didn't speak English, and she actually spoke a very specific dialect of Chinese that no one in the hospital spoke. So for her to be in the hospital with a cancer diagnosis during the pandemic, sometimes only having one caregiver by her side when she has a family of over 20 people, was absolutely heartbreaking and traumatic for us to go through. The only time our family would see her would be for 15 minutes on Zoom that we would have to book through the hospital if we weren't there by her side. And I just think about how technology plus the presence of a caregiver or, a care partner for somebody who's in such a terrible situation. And in this case, it was the end of her life. And we needed that interaction between technology and care partners. We needed it so badly. And I think about every day, the other families who look like my family, but weren't able to advocate for the things that I was able to advocate.
Yeah, really powerful. And one of the themes that has really emerged through all of our conversations, and I've so appreciated chatting with all of you, is that essential care partner, that caregiver role, that as much as technology that we're talking about in the context of this conference is about providers and patients and healthcare administrators, we can't forget that family and caregivers and those who help to support patients are really integral, not just to our healthcare system, but to this conversation around technology as well. And the more I hear you speak, Melissa, and others who are from different types of communities than mine, which is white and English speaking, is that how they characterize family and the supports they need around them are very different than how another individual might characterize family, and that those different races and different cultures have different needs. Alika, I'd love to bring you in on this, talking about this space of, who's left behind, but more importantly around some solutions, like how do we get there together? So what does it look like for those that are potentially left behind by technology? But from your perspective as a physician, as an Indigenous leader, how do we help to bring and support people to be able to access technology in a better way or in a more constructive way?
Mm-hmm. So I just want to start off by acknowledging that there's a lot of stories, not just in the panel, but also with the participants of, fragmented care, outcomes that could have been better if things were done a different way. And as a provider, I've spent a lot of time thinking about it, as have most providers across the country. And we really have an analog system that was designed around providers originally, that now is designed around administrators. And we're digitizing these systems without necessarily acknowledging that the way that things are set up are really for me and they're for the managers that I work with. The fact that we excluded patients during COVID immediately after it was diagnosed without considering the impacts that it had on families and health outcomes of the patients who were now isolated and had no support systems, because the system's not really designed to do that. That wasn't a miss. That's how the system's designed, right? And so I think that that's one important thing when we unpack the question you just asked, Julie, was that we have the system that we created, right? There's no mistakes. Our system's not broken. It's designed the way that it is, right? I think that there's a few things that digital tools allow us to do that are really, really promising, but they'll only be implemented correctly if patients know the right questions to ask. And if we get organized, because I'm a mixed, I'm not just a provider, I'm a patient as well. I'm an advocate as well. I have family that goes through the healthcare system. I've gone through it myself. We have these mixed identities. If we don't ask the right questions around what we want, why are digital tools siloed? Why do I have to go through a specific patient portal when with Spotify, I can sign up with Facebook, my Apple ID, Gmail, like all the different things I'm already a part of, right? And it really comes down to what's designed around whom and the way that we protect ourselves. As providers, I don't want certain people participating in my workflows because it provides an emergent danger to my ability to have the freedom to do what I want within the realm of when you come to the OR, right? And that's a reality that I don't think we often explicitly say. Now, when we then transfer that into disempowered patient demographics, Indigenous patients, persons who suffer physical disabilities, those who can't speak in the language of the healthcare system. I don't say the local language because there's a lot of times that we speak English within communities that are clearly Chinese or clearly Cree, or, we expect people to change themselves as they come in. these things are just magnified. So the issues in Indigenous health are really the same issues that, Melissa talked about with her grandmother when she came in. It's just they're way worse because the disempowerment existed at a different level and had additional layers of context. So digital tools have incredible promise for patients, but unless we're asking the right questions and encouraging kind of that problem solution fit, that market patient fit that answers those questions, it's tough for companies to know like how to design these things, because all they have is this analog system that they're now digitizing, and they're bringing in all of those biases that existed in those systems before.
Yeah, and I feel this is where I need to, look at PJ and unleash him. And we've joked around that PJ needs his own TED Talk because that guy knows this stuff so well. But PJ, like coming into this conversation around that analog system design that we're now trying to force fit, round peg, square hole, or vice versa, to fit a technological environment and to meet the needs of patients and families. And Laura, bring you into this as well from this continuity of care point of view, and the fracturing that patients are experiencing, because we're trying to take, as Alika was saying, an analog system and sort of force fit it into a technologically based system. So PJ, I want to unleash you first. So, take all of your hours and hours of what you could say and give us a soundbite on this. Yeah.
Well, I'll say very honestly that where Alika was talking about the different people who these systems are made for, where Dominik was talking about the digital determinants of health, let's be honest and say it's even more simple than that. Whether it's a stethoscope or a digital health record, we're talking about the commercial determinants of health, because patients don't have a seat at the table when these systems are designed. I feel like you and Affleck channeled all that rage you expected me to get out yesterday, when he said very simply, there is not a single law in this country that grants you the functional access that the Supreme Court says you have to your digital health record. Not a one. And there is not a single law that makes every health record talk to every other health record in your city, forget your province, not a one. So until that changes, again, Dominik, I loved what you were saying about careful and kind care, but a fellow of ours, Victor Montori, an American advocate in this field, would say that it's the commercialization as well, that we are widgetized. And until our rights are brought in day one to day end, from the beginning to the end of our journey in healthcare, until we co-design with our peers, we're never going to be able to fix any one tool, be it the stethoscope or the digital health record.
Yeah, and just to add to so much going on in this dialogue, so many pieces to talk about, but this piece around, things have been designed from a system perspective, right? So, and everything really does, to what Alika was saying, fall into how a system was designed, including our policies. So if we look at legislation like PHIPAA, it was designed for a system at a time when these tools weren't available. And it was there to protect patients, but patients weren't involved in the development of those protections, and things have evolved significantly. So how do we ensure, or we need to ensure, that patients are at those tables when we're rewriting legislation, and not as a consultant after, but in the rewriting phase of it all? We need to dismantle it and rebuild it. And that's not impossible. It's completely within our realm of ability. And then who's at that table as well, right? So it can't be our kind of traditional patient partner groups, but really expand it and make sure who's missing from the table needs to be asked before we even have the dialogue. And then to Alika's comment about, if you don't ask the right questions, well, you have to work together. Providers and patients, administrators have to work together, because you don't know what you don't know. So on both sides. So administrators and clinicians need to listen to patients about, what do we not know? Or, and then bringing in the information to patients so that they have the information about how these systems work, but then layer on, how does it work for me and my lived and daily experiences? So I think there are solutions out there. I think the commercialization piece will be challenging, because things like So UHN has just announced that we're moving to a new health information system with the vendor Epic. And so, you know, that solution is built, but now how do we take the implementation of that system and make it live for clinicians, and then having patients really involved from the very beginning. And, you know many UHN patient partners are on this session today and have helped us pick the solution that we're at, but now how do we look at using a patient portal? What does that integration look like? And, you know, patients need to be hand in glove in those decisions. And then how do those work across transition? So we were having a chat yesterday about our partners at Sick Kids in Toronto, who are partners with CHIO. You know, they also have Epic. And so how do we look at transitions from pediatric to adult care? Because there's, you know, that huge kind of precipice when people go from, and I'm terrified of this because I have a 14-year-old son with a rare condition, and I know we're approaching that transition time for him to move to adult care, and I can't imagine what that will look like. So I think there's solutions, but if we don't put these mandates in place now, then the solutions will get embedded and it will be impossible to pull it apart again.
So let's talk about that a little bit more, and you know, that transition piece that you mentioned, Laura, between pediatrics and adult. Claire Dawn-McCord spoke about that so eloquently in our opening panel yesterday, and quite frankly, her life being put at risk because of lack of interoperability of health records. But let's talk about that piece around the incredible opportunities to include and leverage lived experience across this technological landscape of health and care and the health system. And what could it look like? Or is there leadership happening in this space? And have you seen any direct impacts of patient leadership and technological advancements, or in correcting some of the missteps that we've mentioned here? Are any of you aware of any like sort of specific examples where we're seeing leadership from patients, families, and caregivers in this space?
There are many examples of leadership in small islands of excellence, but none that, to the point of technology, are interoperable. There's excellent work being done at UHN that is being patient-led, that is being working with marginalized populations, rare diseases, but you can't pick it up and move it to a small city in a small town in Winnipeg. It's just, to be the broken record I believe I need to be, until there's legislation and education of what people's rights are and why it matters, then there's not going to be any changes. I mean, right now, you can't get your data. You can't get your portal, or you've got 6 portals that won't talk to each other. But that data is making other people very, very wealthy. And we need to address that health equity problem. Every piece of data is health data. And every piece of data, we need a European rule to control. We need a right to be forgotten. We need a right to know what's being said about us. We have 0 of those rights.
So I'll just weigh in here as well. And I think the discussion about commercialization is really important when we talk about digital health tools, because you're getting individuals who see a problem and they're trying to fit their solution into that problem. But then you need a market where they can sell that problem to stay sustainable, right? There's just basic market dynamics. But what's happening is that the persons who are paying for the product aren't actually providing what patients want. And I think that part is within the structure that we have. You know, health regions purchase, you know, big EMRs like Epic that are extremely complicated, that are built on rules that, because of the complexity, aren't very easy to go back and kind of rework. I mean, I started a project called Safe Space Networks with 26 BC friendship centers, and it's centered around collecting patient experience safely. That way it can impact care. I've even found, as we've been building our code, we're eventually going to reach a threshold where we can't go back and change some of our assumptions. They're baked into the way that we did it, right? And so you have these companies that are now trying to respond to, you know, these social ways where patients now can speak out on social media and actually get attention, where you can get disadvantaged groups that are Black, Indigenous, persons of color who are now finally getting attention. We're finally talking openly about systemic discrimination. You know, these things were not baked into products at the beginning of their product market cycle, you know, and they're now very complicated products that they sell to health regions with promises that they'll satisfy patient needs, but the health regions aren't actually checking whether or not what they're being told is consistent with what their population needs. right? And so I think sometimes we have the inclination to blame the digital providers for this, when in reality, it's our own systems that are not evaluating it properly. You know, one of the discussions that we had when we discussed racialization in BC is in our model, there is no market. You know, you can't differentiate between the differences in racialization within Vancouver and Prince George, because I can't openly talk about racialization or else I'll get charged with unprofessional conduct. You know, I can't talk about what I see providers do. I can't talk about what patients do because of the way that our regulatory mechanisms are designed for this analog world, right? The burden of change is put on the shoulders of patients who go through the systems, and that's what we need to change. You know, and I think the way we change it is by identifying who buys these systems. You know, if a health region buys a system and it doesn't work out, don't necessarily attack the technology provider first. Talk to the person who's paying the money to implement the system, you know? And it's understanding these market models and how we can impact them that I think will get a lot of empowerment within the hands of patients. Like PJ was saying, this is a commercialization problem, but the market is responding to the payers. They're not responding to the users, right? And that's an on
that. I need to jump in on that, because what you said about whether you're Chinese or Cree, you're made to speak English is a more fundamental problem, even than having the market correct itself. Digital technology is a language. And everybody famously knows that 3 whole hospitals in Ontario, a couple in Europe, and 70 in the States will let you get your record on your Apple phone. But what they don't know is that the standard they're using is a language, like English, like Cree. But that language has many, many different dialects. To go to Melissa's point, you speak Chinese, but does anybody in your hospital speak my grandmother's version of Chinese? There's a simple solution. It's called creating, and this is a big word, creating a taxonomy that is common. So there are no confusions. The second you have, again, banging the gong, a legislation that says you must use language that every system understands and can. If you have an Excel spreadsheet, you have to be able to translate it into a different company's spreadsheet. That's something that is starting to happen in the industry, but not for health records. The second you have that, what a word means is the same in every digital health record, then we can talk about all the other problems. But until then, until we own the language, other people use our language against us.
Can I just add to, I mean, I think that there's the digital side of this, but I think, and we talked about this in our prep, so during COVID and everything switching to virtual care so quickly, it's highlighting where some of the gaps are in our system. So it's like, we knew that there were gaps, and now with COVID and now moving to virtual care, those gaps became much, much more apparent, or we listened differently. Maybe they were apparent and we just weren't listening in the right way. So, and PJ, with some of the crowdsourcing that you have done, you know, what really struck me was this idea of communication. So are we helping people to understand how to communicate well, that there is value in learning how to communicate well, that when we work with patients and use plain language and engage them in care, it doesn't take longer. It's just the right thing to do. And you know, I think we call communication soft skills, and it should be a competency. So how do we build all of this into digital care, virtual care, how we engage, that this is not that focus on the system, telling people, here's what you need to do, versus a dialogue about your care, and then again the cultural competency to understand and ask the question. So what does this look like for you?
It's such a great pivot, Laura, like such an intelligent pivot. I feel like you've taken on my moderator role, which is great. And it is like, it's bringing us back to the topic of this entire virtual conference is about compassion and technology and patient leadership in this space. And, you know, Melissa and Dominik, I know you're going to want to weigh in here about the comment I'll make about, you know, fragmentation in care and continuity of care, and Laura's comment that she just made about communication. We know that you know, close to 95% of patient complaints really are grounded in communication. And it comes down to what Alika and PJ are talking about, you know, poorly constructed systems that are provider and or organizational centric. But it also comes down to to, continuity and fragmentation and how people are experiencing the system in that respect. And so, Dominik, maybe let me throw it over to you for a moment around this space of technology and continuity of care, and from your experience as a provider, the concerns that you have, but also where you see some potentials and some possible solutions.
Yeah, and I think beneath what we're all speaking about here, which is kind of records and information and how we communicate in healthcare, and sometimes even the jargon that we use, and that jargon not being accessible to people, there's this concept of continuity that's behind the scenes. So I've permission from one of my people in my practice to share a story around continuity and what we'd call access. And oftentimes people see these two things as a trade-off. Either you can have the same clinician, or you can kind of have convenience and person-centeredness in how you access the health system. But this story shares that actually it's both that are important. So I'll call her Emily. Emily's a 23-year-old in my practice. She's a student. And so far, we spoke about things like immunizations, cancer screening, kind of bread and butter, proactive family practice. Just a few weeks ago, through the summer, a car collided with Emily's bike. She fortunately survived the crash, the collision, but she needed surgery for her leg. And several weeks later, we're working on a recovery. She has a tough time moving, so we're actually meeting virtually. So she's at her home, I'm at my office, and she says, I feel tired, but I think it's just the pain medications. And I explored a little bit further. I know her well, and it's strange that she feels exhausted within just a few minutes of starting her physiotherapy. And I probe a bit further. She's even a little bit short of breath when she's explaining the story for me. And because of the virtual visit, because of that digital interaction, I can't examine her. I don't have her vital signs. I can't listen to her heart or her lungs. But I knew, because of the fact that I had lots of visits with her before, I was her family doctor, I knew what she looked like when she was healthy. And she sounded anxious, her face was flushed, and she even showed me the heart rate on her smartwatch. And because I knew Emily well, because I had that intuition about her, I knew what she looked like when she was fine and healthy, something told me something was wrong with her. So I shared with her that I was worried, what I thought was going on, and that she should go to the hospital. She trusted me, even though she wasn't happy about going to the hospital, but she went. They did some tests, and they actually diagnosed her with a pulmonary embolus, which is a blood clot in her lungs. And this would have really ended her life if it weren't for our visit that day. And it had the potential to be very serious for her. So I think through this concept of access and continuity and this contrast that people draw, and I know that for Emily, it was the access that gave her the visit, but the continuity that saved her life. So both are important. It's not a trade-off. And in fact, with technology, just like in Emily's story, we know that technology can make sure that people who need continuity, even if it's for their regular follow-ups or preventions and everything like that, can get it. And then when it matters most, they have someone who they trust, who knows them, who can keep them safe and give them that kind of kind, careful care that we speak about wanting to have for everyone in the healthcare system. So I think that's so key as we look to digital health in the coming few years.
I'm also hearing that note, Dominik, and thank you for sharing that. Mm-hmm. And the power of story comes through yet again. And what I'm hearing in that as well, in your voice, in your tone of your voice, mm-hmm. is that compassion piece. Yeah. Mm-hmm. That piece of I know her. I trust her to share with me as a patient. We have that connection. This is human-centered care. And Melissa, let me bring you in here where that could potentially break down and be fractured, where that continuity might be impacted by technology in, not such a positive way as Dominik was just sharing, but in more of a negative way.
Yeah, I mean, I think, and everybody's really kind of outlined this here, but I think about the nuances healthcare and digital tools coming together. And I think about how, we've all talked about, and I want to build on this, but, who's not in the room, who's not at the table, but who's also not making the decisions. And it's those nuances that we need to make sure that there is equal say across the table, that patients, that caregivers are not just a checkbox when we are co-designing together or co-creating together, and that there is meaningful engagement, and that we are acknowledging and recognizing the time, work, and energy that a number of people go through on a regular basis when they're oppressed. And I really think about how, it needs to be so integrated. It's not just, technology will solve this. It's an easy fix. As PJ was saying, it needs to be centralized and it needs to come together instead of being in different pockets. And I really just think that we all talked about, essentially how we need to see healthcare in Canada equivalent to providing justice in Canada.
Melissa, I want to jump into, it's been referred to as modifying healthcare from an old model to a new model, but it's not just the digital shift. There is a paternalism, which we may not want to talk about, but there's a very, very strong deference to our health practitioner. I've had, as you guys mentioned, I did some informal polling of co-op members and people on Twitter. 50 or 60 people replied in the few days before we recorded for this. Most of them have never had the opportunity for video because their providers did not choose in COVID to embrace video. The vast majority could only use phone. I've had personal stories conveyed to me in confidence of doctors calling them while their kids are in the car and they can't record the notes in their files because they're still, their computers are at home, or I'm working in the backyard right now. Hopefully I'll get that note and get you back. And they never do. And the appointment is missed for another month. These aren't issues with technology. They can be fixed by technology. These aren't issues of empathy because I believe these doctors truly care, but they've misplaced the patient as the center of that care. And we need rules and we need a very educated and active patient population to get that just care in general. But to your point earlier, having your grandmother have an iPad in her hands changed things a lot, right? And that education was something you could provide, but another family couldn't. So it's not the digital, it's the supporting technology that's going to bring it all together.
And I think it's all about who, like the perception of who owns the information, right? So is it the patient's information? Is it for providers to communicate together? It is a tool for communication, but ultimately, patients should be owning the data and being able to use the data. And so how do we ensure there's equity for everyone being able to access the data and use it and in real time? So real time, so at UHN, all of the results go in real time. And when I've gone for appointments outside of UHN, I'm so frustrated when I can't get that information within, it takes 10 days. And I think, well, why? I just, I can manage my health, and we surveyed 16,000 patients. Actually, we sent out a survey to our portal users. I think we had about 75,000 on at the time and received 16,000 responses in 2 days. And 94% said they'd prefer to receive their results in real time. But there's also a feature where you can turn off the email notifications and decide when. So that patient autonomy and, choosing when to receive that information, good news or bad news, and that question included, even if it included bad news. So the answer's there, and we just need to not be afraid to embrace that across the country.
I want to go down that rabbit hole, and yeah, Dominik, I'm going to throw it to you, but I want to go down that rabbit hole, and I want to say that topic, Laura, about who owns the information, who gets to see the information, who gets to decide when you get to see the information, has been a hot topic in every single panel so far. Now we're only the third panel, but the previous two panels talked about this. It is a hot topic on social media. It's a hot topic amongst, I'll use the word educated patients. And what I mean by that are patients who are really active in the system because of the complexity or chronicity of their care situation. And you hit on a really important point there. If you don't want to know, you can turn off the notification, but you have choice and agency. So you can tell where I'm at with this. And I will offer a personal anecdote about how this affected our family when we weren't able to access information, and how it negatively impacted on my child's care. But Dominik and Alika, as physicians, I want to bring you into this. Why is it that in some examples, many examples, physicians are so averse to this? And I'm being told it really is coming from the doctors. They don't want their patients to see the information until they've had the conversation with them first.
Alika, did you want to go first?
Sure. I'll jump in here. I think it's the wrong question, to tell you the truth. The question is not about who has the information, it's who has the power, right? And I don't think that patients think about this. As someone who operates in real time, patient comes in, I start an IV real time, I give the medication, 5 seconds later, it has its effect. I am acutely aware at which point the patient can't actually provide any feedback to tell me what they want to do. And patients often come to me in situations where they're in a bind. They either get the treatment or they die, right? That is the harsh reality of being in acute care, particularly when it comes to surgery. And so I've had a different experience, I think, than other providers who sometimes do things and then wait for 3 weeks to see whether or not there's any sort of impact. And so watching patients go through this, one of the things I often do when I do patient interviews or engage with people that have had, a difficult traumatic experience that they're trying to work through, is I talk with them at what level did you feel like you lost control, right? If patients had full confidence that the information that providers receive on them would be utilized in a way that always accounted for their thoughts, their desires, their wants, their needs, etc., well, you wouldn't be having the discussion about who has information when and where, right? Because you'd have trust that the person would cede the space. And I think as providers, we don't talk enough about how we have 100% of the power in a lot of situations and you have zero. And when we talk about compassionate care, it's, am I willing to give you compassionate care? Not is it a part of the system, right? And so when you have a system where you don't have to do things, and we've been talking about mandates and legislation and other things in a variety of different contexts, the default is that you don't get it, right? And so I think one of the reasons why patients don't receive the information is because that's the way that we've always done it, right? It's not a good reason. It's not an acceptable reason. I don't think it's a reason that the majority of providers across the country would actually stand up for, but that is the reality. This is the history that we've inherited, right? The second part is that we're not enabled to provide the information, right? So I provide you the information without context, you get upset. I have no structures in place that incentivize me or provide me additional support for providing good care to you, right? Keeping you up to date, asking you questions, all these other things. And then the third part is how we actually manage risk within the system, right? So if something goes wrong in your care and I even had a tangential connection with it, the system will try and put me in a position where it's my fault, because the system is designed to shift blame onto persons who are not inside the system, and providers are not really in the system. We're contractors that provide roles. We're cogs in a wheel. I'd love to believe that I'm really important in the care of my patients' lives, but the truth is I'm interchangeable, right? Even if you have a great relationship with me. And so in the context of history, in the context of disincentivization or lack of incentivization, and in the context of risk, it actually makes a lot of sense behaviorally that providers don't do these things for patients. Now, how do you change those things? Well, you have to actually address those three aspects directly. And I don't think that patients even have the context any of the things that I shared unless they sit down and talk to a provider, because we just don't talk to patients about this, right? Compassion cuts both ways within the medical encounter. Power, on the other hand, cuts one way in the way that the system's set up. And so if patients want the value exchange of getting more compassion within their care, We have to rework these systems of power, but patients also have to meet us halfway and help us to mitigate the risk that the system throws onto us. You know, it's not my fault all the time that you got your lab work late. You know, I might have been treating a critical patient. I might have had, you know, a shutdown. And if Epic shuts down in Alberta Health Services, I mean, there is no way for me to access your information, but we don't have these nuanced conversations where we see each other as people because of what the system puts us in the position over and over again. And we have a ton of opportunity with digital tools to do it a different way, but only if we ask the right questions.
Alika, it's not just digital tools. You raised such an important point. I have to step on the end of it again.
Yeah.
If you have true transparency and accessibility to how many events of a certain type happen in a healthcare system, how many patients request the data, if there was meaningful accessibility and transparency, if you could see all that data and patients could see your data, and experts in the making of these systems could see the data and the effects, we could have a dialogue. It's not just power, it's the gatekeeping of the knowledge of what went wrong and what went right, to your credit. We don't ever get to see any of that. What's the one piece that's not interchangeable? The patient. Which part is never considered when building all of these things?
Julie, I'll jump in. I agree with, you know, all the wisdom that the panelists are sharing so far. The comment I'll have here is, I think, to a quote from one of the founders of the quality movement, and who said, "The secret of quality is love," right? And something like the sentiment that the secret of quality is care. And I think to this concept of joy in work that Alika shared in our health professionals, and how, you know, half of docs report symptoms of burnout. A third of nurses look for another job within a year. And, you know, how digital health and how our EMRs and that computer in the room, the stranger in the room, is actually burning people out, right? And is taking away from that joy in work. And how do we get that out of the way? And how do we change that in a way that returns that joy in work? Because caring for people at the end of the day, and this deeply personal responsibility that we have, to PJ's point, to actually care for people is actually highly joyful. But for some reason, for whatever reason, we're putting these barriers in place to burn people out and to stop that joy from happening. So how do we get out of the way? And how do we let that kindness, that care actually come through in both ways?
You know, just to expand on that too, and some things that PJ said as well. I mean, as a provider, I mean, I know when people have been treated poorly in the system. Like I know what signs to look for, right? When a patient sits down with you and they give you a long 3-paragraph memorized presentation of who they saw, when they saw them, who started their opioids, who stopped them, how they've been trying to wean, you know that they've been traumatized in the system. Somebody at some time has said, "I don't believe you, and because I don't believe you, I will not provide you care," right? And I think that we don't manage conflict well as providers. I think that this is a big missing piece. We don't know how to get yelled at. You know, we don't know how to not take things personally sometimes. I remember an experience with a patient in pre-assessment clinic years ago where they had gone through kind of a 2-year workup because they had some complexity. And I told them that they weren't appropriate for our center because they were, because of a variety of different factors. And they just started screaming. And 2 minutes after they started yelling, the nurses came in and asked if I wanted to call security. Right? And I told the nurses, you know, it's okay. I know they're just upset. And they continued to yell. You know, 10 minutes in, they started to cry. You know, and one of the things that I'll always remember from that encounter is the patient told me, "You were the very first person out of the tens and scores of people that I've seen in the last 2 years that actually let me yell at them. And thank you for that. I needed to get that out." They weren't mad at me. They were just frustrated. You know, but we don't learn this in medical school. We don't learn this in residency. You know, we have increased symptoms of burnout, but a lot of it is we don't learn how to manage our own emotions. Like, take this trauma. You know, what type of system has someone deal with a critical event, and then someone dies, and then you get up and you move on with the next patient like nothing happened? That is the expectation within the medical system when it comes to providers. Does that excuse bad treatment and the fragmentation of the system? Absolutely not. They're two different issues. It is not the patient's fault that happened, but this is the context that patients can kind of bring into their conversations with providers. We don't know what to do sometimes either. We're caught in this maelstrom of, negative emotions, and we don't know how to get it out again, right? And so that's the compassion that is really meaningful to us. And I have a lot of different experiences where patients have shown a lot of compassion to me, and honestly, that carries me through days that are very hard to deal with sometimes.
There's such a human aspect to this. I mean, that is the foundation for everything healthcare, right? Is humanity and being human with one another, and hearing such powerful words here, compassion and empathy and emotion. And one word that's coming, through more often than not is this power conversation. And I can't help but go to, and this is one of our themes that we talked about as a group, was, ownership and power and agency over information. And I can't help but think that some of the tensions in the system as well are attributed to, patients feeling extremely vulnerable. You feel like you shed your persona, who you are, any power that you have as soon as you walk in those doors. It's almost like you're stripped naked. I'm not going to get agency over decisions about myself. I'm not the one who has access to information. I'm, in fact, not even allowed to read the chart in a doctor's presence without their permission. And so, let's get into a bit of this topic. And it's a topic that's coming through as well with the listeners, the people who are in our audience right now. And I'm going to start to weave in their questions because we're more than halfway through our conversation, and it's been amazing. But this conversation about who owns our health data, and there's this clear demand that's emerging from patients and the public around transparency, where information goes, who gets it, who gets to use it, who gets to benefit from it. And while, we have a Supreme Court of Canada decision that patients, the health information belongs to the patient, we have little control over it and how it's managed. And so I'd love to talk about, some of the issues around this data ownership piece and how it impacts on fragmentation and continuity of care, and some of the issues that you're raising, Alika and Dominik, around, that human connection in care and frustration in care, both from a provider point of view and a patient point of view. So, Laura, I know you're doing work on this in your professional capacity and working with different governance committees. And Melissa, I'm sure you as well, working as a family engagement navigator in your capacity. I'm sure you've both sort of run into these issues around ownership and agency over health information. So Laura, maybe I can start with you and then throw it to Melissa.
Yeah, for sure. So, I think actually we are making good strides in the area of ownership. I think, recently in kind of data governance committees, we have been having these dialogues around ownership. Where it comes up a lot is in research. So, or in commercialization, and when we use external vendors and who owns the information, and within research as well, like what is shareable, de-identified or not. Typically there's good legislation to protect around anonymity and de-identification, but then ultimately that information then you can't retract as a patient. And are you actually giving permission at every step for that information to be shared? And do you know every time your information is shared? And there's, through systems like blockchain and other technologies, there has been discussion about people being able to individually say, I'm okay with sharing this with this research project and not with this other. And anytime your data is requested, you would get notified. But again, I know blockchain has been kind of thrown out as a possible solution when there's maybe other less complicated ones. In terms of research, maybe I'll just draw on a personal example too, is an ownership of information is also who's driving these questions. And so I mentioned before that I have a 14-year-old son with a rare condition, and his condition is called GRIN1. So it's a neurodevelopmental condition that affects his GRIN gene. And so, with technology, so connecting us across globally, we've been able to not only connect families, but now researchers. And these researchers in different countries, Spain and Germany and Canada and the US, they've been creating their own registries, so databases that collect patient information in order to do research. Well, we're proposing actually that maybe our foundation, so CureGrin, is in the center of that, so that why are we spending all this time collecting information in different registries when you can actually be a hub and share that information with patients in the middle being the authorizer of doing that. And you know, just 2 weeks ago, we had a collaborative come together of 20 researchers from 12 different countries sharing their research projects and then how they're going to collaborate together. And that is completely parent driven. So they're getting the questions now from the parents. And so it's an example of who owns that data. Well, we're still actually keeping control of that information, but these researchers are kind of excited and really want to kind of partner with us. And there's been a flip for them, realizing actually, oh, this is a person, and they seem almost more driven now that they've met the families and the children. So there's lots of different realms where we could talk about data ownership, but I think research and commercialization are both the two big areas for that.
Yeah, and I guess when we talk about agency as well, you know, that's a massive part of, you know, accessing the patient record. But I also want to talk about the loss of autonomy when you enter the healthcare space as well, that sometimes you feel that you don't have autonomy over your own body. And, you know, when you also try to get access to information about your own body that somebody else is writing, and you have to jump through hoop after hoop after hoop after form to just get the information on your body that's imperative to you. It's awful. It's awful for families. It's awful for patients. And I even, you know, remember that somebody I know eventually had to pay for their health records, which is awful in itself. But then when they opened their records and read the things that their care provider wrote about them, and I think a number of us can attest to this, that we were the non-compliant patient. We were the non-compliant, client who was pushing back against this and pushing back against that. It's like, just think about the impacts of that, right? In addition to the access to the record. And then I think about how, the communities who might not speak English, or, there's so much medical jargon as well, that there's no version of a plain language or translated version of your health record. And that's another barrier to access on top of that. So when we're talking about the patient record, it really just comes down to, we are not able to access our own information about our own bodies.
And Melissa, you make a great point. Sorry, I was just going to add around the readability of the record as well. So we can push out all kinds of patient data and information, but is it usable? Does it cause more concerns? My pathology report is a fantastic resource, actually, that
Jason Wasserman.
Right? Amazing individual. And it actually explains results in plain language. So more and more of what we do, we need to document in plain language, but then also these resources are really invaluable.
Mm-hmm. So let me just be very clear about that reference that Laura just made. Dr. Jason Wasserman, who's a pathologist at the University of Ottawa and the Ottawa Hospital, has put together a website called mypathologyreport.ca. And if you want to learn about how to understand your pathology report, he is slowly weaving through any potential diagnosis from those that probably are more prevalent to those that are least prevalent. and he's writing up a layperson description of that diagnosis, and he's including in that exceptional images by an artist colleague who's also a physician to accompany that, to really describe to you what you're seeing in your report. So mypathologyreport.ca, go check it out. I want to pivot us to some of the questions that are coming from the audience, if that's okay with all of you. And I'm really liking this first one from Mark, and I'm going to read them out verbatim rather than try and adjust them here. So Mark says, government is notoriously slow at knowing how to regulate the digital realm. And he uses examples of social media and video streaming. Considering the pace at which health technology evolves, how do we build capacity in decision makers to understand technology and its implications to improve care at a faster pace? I don't see any hands going up. Who could possibly want to answer that?
I want to take this then. I'll chew on it.
I'm teasing you.
You want people to care. You have to reach them where they live. You want a politician to care. You have to reach them where they live. The patient too, they need to know why it matters. Many patients still don't want access to their health records. But if you address it differently, say, do you know how much money is on the table? Do you know how much money you could recover? Do you know how much research you could build for your constituents? That's going to motivate a patient. A politician. If you say to an administrator or a hospital, do you know how many patient safety errors you could erase? If the patients simply read their files as they were being created, how many lives could be saved? Before COVID, patient errors, safety errors, medical errors were the third leading cause of death. If you tell to the patient who doesn't care about their record, it's just good to have, and you give them an example. Do you want Gmail to be able to decide which emails you should receive? You wouldn't really like Gmail then, would you? There are many ways to reach this, but we as patients, Alika, I have to agree with you. I represent patients. That's my only job. I take no money from anyone else, but we're falling down on our responsibility. We won't get into the world climate, but democracy is a right you have to access and use to keep. And so is your personal rights to your data. The Supreme Court says you can have it, but show me the patient that really does. We have to activate ourselves to activate everybody else. And we have to build bridges and speak the languages that's going to matter to each other. And that's education. And that's where we got to start.
You know, just to add to what PJ's saying, I think that health responds to market forces, right? Like the creation of Medicare was a result of the Great Depression that happened in Saskatchewan, and more people in public institutions not receiving good care, not being able to go back and farm and other things. I mean, that was the impetus for creating medical care in Saskatchewan. No matter what we want to say about retroconning its kind of origin, there were market forces at play. I think that transparency will be the new privacy, right? People want to know what's happening as it's happening. And not to talk about the US election, but it's crazy that we can actually see in real time reporting of votes down to the districts that they're reported in. This never would have been imagined, 10 years ago, that you'd actually sit there and you'd see in real time as people were, making their decisions near at the same time as persons who pay for special access to this information. There will eventually reach a point for the healthcare system where every complaint, every concern, every miss, every pharmaceutical miss, every misdiagnosis, etc., is going to be publicly known. And so the system can either catch up with this and manage it in partnership with patients, or we can let it happen to us. And you're seeing more and more that patients are moving to social media. And the CEO of a hospital may want to reach out to a family member whose grandmother was adversely impacted, like Melissa, or whose child was adversely impacted, but they can't because of the risk that goes along with it. So we either manage this or we don't, but the market is going to force us to come to this reckoning. And so that, I think, is the greatest glimmer of hope for patients who are caught in the middle of all of this. The world will force health to change.
But Alika, the other side of market forces is that markets fight back. They become very defensive and they choose to block customers and to block information. Exxon fought for decades against the research they conducted and knew of in their own home about what climate change was occurring because of their products. So we need the legislation. We need the rights enshrined in law otherwise market forces become cronyistic effects, and we don't get the true market forces. We get the power versus the disadvantaged.
Let me bring you into another question. And Dominik, this might be one for you to start us off with. This is from Kathy. Our healthcare technology is organized around business workflows, and these are necessary. What would it look like if a patient-centric view existed on top that brings focus to the patient-specific goals and integrated care plans, along with possibly measures of success from a patient caregiver view? So she's very much on that patient focus, Dominik, but I'm also asking you to add a bit of a provider lens to this question.
Yeah, and I'll build on what PJ said that I really loved, and that, informational continuity or our access to our data is not just a matter of, awareness and comfort and kind of for fun. It's a matter of life and death. And I think of the Greg's Wings story, right, with Greg Price, and how the fact that he had to find his diagnosis online to know about it and to take action. And because there was no one kind of connecting the dots for him along the way, that led to such a tragic outcome. And that's not an isolated story. That's something that happens probably in the hundreds, if not thousands, even in Canada every single year. Even though, we work on making it better, it still happens. So it is such a burning platform. I think
let me share with you a personal story too, because I absolutely agree, Dominik, and it is impacting people's lives every day. And in our situation, we transferred from one province to the next, from one pediatric hospital to another at the end of Kate's life. So decision was taken that she would be sent home, that there was nothing that the hospitals could do. But the absence of transfer of information resulted in an 8-year-old who didn't have appropriate medication support at home. She needed IV morphine to control her pain at that time. Resulted in no information being sent to home care for the appropriate deployment of nursing, and resulted in the palliative care physician sort of arriving to our home, which we were grateful for because that's where we chose for her to die, but with no information about what he was going to encounter when he walked into the house. So here's one direct result of that impacted our family. She needed a much higher dose of oral morphine because we were waiting for the IV morphine pump because of the miscommunication, the lack of transfer of information. So as physicians, you can imagine what it would look like to access a higher dose of morphine that she required. It's not available at Shoppers Drug Mart or Rexall. So my husband drove around the city for the better part of an hour, hour and a half, possibly 2 hours, looking for the morphine that she needed. And those were the last 2 hours of consciousness that Kate experienced. She slipped into a coma. My husband arrived home and he missed the last 2 hours of her consciousness because of a miscommunication, a lack of transfer of information, a lack of continuity of care, of interoperability of our health information. And you can hear it in my voice, the emotion there and the anger and the frustration that he was denied that. And so what we're talking about right now, and I know Laura, you've got stories, and Melissa, and probably all of you have stories about this continuity. This is something that's impacting people day in, day out, life or death situations, and situations of quite frankly impacting people for years to come from a traumatic point of view. And so, I move us back to that question about that I just posed about, what does it look like to support continuity and compassion in this space, and what's it going to take? I mean, what is the technological bridge that can help to solve these inequities and these breakages in care? And we've talked a lot about a number of different solutions, but if you had to really articulate one, that would really help to change this disconnect that we're experiencing, what might it be?
So I'll jump in here, and I think this is a tool that you see expressed in silos, but that's needed across the system, and it's decision-making support for providers to humanize the medical encounter. We don't ask when someone's dying in front of us, like what they actually want to get out with the time that they have left. We assume that they want, a surgery with a 1.5 year, recovery time. And those, 15 months may not be very high quality life. I've had the opportunity to sit and reflect with patients on what they actually want, and people have chosen, instead of life-saving surgery that might give them a few more months, they want to spend their last few weeks with people that they care about without the impact of medications that change their consciousness, or pain that changes the quality of the conversation that they live in and live out. And like Julie, you've shared your experience with me before, and I mean, my heart honestly breaks every single time that I think about what you went through, when I think about my own experience as a parent and seeing other parents go through the same sort of thing. But you don't think about this when you're a provider, right? You click into this clinical mindset where I'm a hammer, you are a nail, and my only question is, am I supposed to hit you, right? And that is a reflection of the system that we've built. That's a reflection of the training programs that we've created. And that's a lack of, I think, providers in particular realizing our own deficiencies. Asking your patient what they need is something that could be triggered through a digital tool. An EMR can have a little pop-up every time you put in a note. Did you ask your patient what they actually wanted to get out of this encounter? It's not really complicated to have people reflect on the care that they're providing, but you have to create the space in order to do it. And I think we're really afraid as providers, like, just to talk for myself and, people that I know well throughout the system, we're afraid to enter into these conversations because we don't know where they're going to go. We don't know how to deal with the emotions that are going to be involved. It's traumatic for us, it's traumatic for them. And this is not what we're taught when it comes to providing good healthcare. Good healthcare is me being completely isolated emotionally from you, not engaging as some passive third person within the experience, providing you somehow, quote unquote, objective information that in the end is very, very subjective, right? But I think that is a digital solution that could be integrated across a lot of different workflows. Pause and ask your patient what they want.
I'll add on very quickly.
Sorry, go ahead, Dominik. Yeah.
There's this concept of we have a limited amount of time with people. And I think the next big promise in digital health is taking away some of the kind of the rote stuff, the information, the basic information gathering that we have to do to get through the visit, kind of the clinician on autopilot mode, and saving that time that I have with this other human being to really get into what matters. So the digital stuff can do the stuff I have to do that a computer can learn and everything like that. They could take that information, carry it forward, so we're not re-traumatizing people. And then for the small amount of time I have with someone, I could really dedicate that to meeting them where they're at, to kind of connecting as a human, to giving them care and actually caring for them during that time.
Laura, there's a question that's coming in here that really builds on this, and it's from Isabel, and it says, so much of this begins and ends with agency. And at the root of all of this, are we going to build or rebuild a digital system that puts agency and autonomy in the hands of the patient? And I think I would add to that, looking at this from a systems point of view, and you work in a very significant healthcare system at the University Health Network, are we able to do that at a systems level? Are we able to put agency and autonomy in the hands of the patient?
Yeah. I mean, I'm the eternal optimist.
Good answer. Next one, next question.
Yes, we can. No, I am the eternal optimist. I think we can do anything with enough energy and will. Is it going to be hard? Sure, it'll be painful. Like, there will be a lot of really hard conversations to be had about that. And I actually see that providers, they want it too. Like, I think we have a lot of unbelievably compassionate, caring providers who are also stuck in this system of control where, what Alika talked about earlier, that who has the power? So providers do, but that's also put on them to have that power. So how do we share the space of power in a different way? And I think it also, Mel talked about this earlier, where we can be broken down into parts of diseases, especially those who have, chronic disease, and you're broken down into parts of of your disease versus your experience of health in the system. And so it's really challenging because, you know, when we were talking earlier about what do we want? What is this idea that Alika had about a forced function of saying, what's important to you? And I reflected, I'm like, what's important to me? You know, when I had hundreds of appointments in 1 year for my son, or my husband was going through his transplant journey, to be seen and heard, right? I want to be seen and I want to be heard, and I want safe care, but couldn't physical safety also be attributed to or have an alignment with psychological safety? Like, that's important. And I think because mental health hasn't been considered in the same way and given enough attention in the same way, we don't think of psychological safety as a forced function. Like, we would be really upset if we missed something on blood work, but we should be equally upset if we don't have an opportunity to ask those questions as to what's important to you when you're in your final days and moments. And Denise's comment yesterday just continues to live with me in terms of her father and just wanting the iPad at bedside so they could drum him into his, you know, next journey. Like, it sits with me because that's a question. That's a moment that's lost forever. And that's psychological safety that I think we need to consider. So absolutely. I think we can do it. And I think we need to think of it as a patient journey, like a care pathway, instead of these episodic moments of, it's your cardiac care, it's your, you know, it's neurology. I think we can do it differently, and it's gonna take time. But yeah, mm-hmm. I think we're actually on a bit of a path to do that. I don't think this would be brand new.
And so, you know, pivoting you guys again into maybe a last one or two questions here as we're down to our last 15 minutes. And this might be a tough one. I mean, I don't think any of us, you know, have legal backgrounds or legal expertise, but there is a question here about the very different approaches by provinces and territories. We have 10 provinces, we have 3 territories, very different approaches to healthcare. And so how would we as a panel recommend we create a common approach, then legislate that all healthcare units adhere to a common platform, a common integrated technological platform, apart from these fractured existing digital solutions that are clearly supporting what we've all been talking about as a flawed system or a flawed infrastructure? That's
Can I comment briefly?
Oh, Dominik, go for it. Yes, yeah. Thank you.
There's something Don Berwick talks about. So he's the former president of the Institute of Healthcare Improvement and the leader of Medicare and Medicaid under Obama. So the same person who often quotes, the secret of quality is love. So the same kind of thing. And it's the 3 eras of healthcare. So at first you had this Wild West area where anything goes. Next, there's this area of, you know, legislation and forcing people to do the right thing. And then third is what he calls the moral era. So treating professionals as professionals, but then also making sure that our health professionals are supported and meeting the person in front of them where they're at and treating them as a human, and supported in actually that kindness forced function, if you will, or that caring, and not just at the end of life, all throughout their entire pathway through the healthcare system. So I think that's really the secret of where, the secret sauce, if you will, of where we could take this, right? Driving into the moral era of healthcare, and not this kind of the Wild West, or what we'd call the control or the government control area. It's the support and the moral area.
I think we're seeing that pursuit of the moral era of healthcare, in my opinion, at least from what I've seen in a time of COVID, of patients and families and caregivers in particular are speaking up about, and care providers for that from that point of view, around the moral distress that they're seeing in decisions that are making, and restrictive policies that are being put in place, and challenges, not just in hospital care, but in all our care settings, long-term care and congregate care as well.
So I'll follow up with that. New Zealand actually has consumer rights legislation related to health, where you actually have prescribed legal rights as a participant in their health system. And it's interesting to me that we have the Canada Health Act, but we don't actually have any framing of, you know, what patients' rights actually are. And I think that that's a first step. I think it would be hard for any politician to say that a patient should not be entitled to certain basic rights. As far as the content to that, I think there'll be a bit of debate, but I think we could all agree that certain things that we talk about here are universal concepts that everyone should accept. And I think the other thing that we need is we need leadership from the federal government. You know, the Canada Health Act is not a policy, it's a fiscal agreement. It's saying if you don't provide care in this way, we will not give you a dollar for dollar penalty to not providing care. You know, and I know that we attempted in the previous healthcare transfer under Minister Philpott to tie things to long-term care and mental health, etc. But in a publicly held healthcare system, if you don't have a competitor who can accept care, and I'm not suggesting privatization by any stretch of the imagination, but someone other than just a health region or a provincial health system that's publicly funded, it's tough to reallocate those funds. You know, one of the things that Indigenous communities are starting to argue for is that if you don't deal with racialization, transfer your healthcare transfers to us. You know, let Indigenous people build their own system. You know, it's constitutionally grounded, and it's clear that, you know, 1 in 5 patients in Saskatchewan are of Indigenous descent. So move $1 in 5 to Indigenous health systems where they don't have to deal with racialization. You know, I think that this is the trigger to have some of these things enshrined in legislation, something that gives you consumer rights as someone who accesses a system, and then some sort of penalty that goes along when the system doesn't provide what you wanted to provide. And the third part of it that we've kind of been talking about but haven't said straight out is you need choice. If you have a single provider and no one else in the country provides that type of care because they're a sub specialist, you don't really have an option to go anywhere else. You know, virtual care has opened up the opportunity for you know, continuous care with providers across the country, right? And so that opens up options that you never had before as a patient. You could only see the doctor or provider that was inside your geographic location, right? But there needs to be incentivizations that are linked to having a relationship built over time. Patients should be able to say whether or not they trust the provider. Patients should be able to say whether or not they feel comfortable, whether or not they're honest and open with them. And I think technologies like blockchain, which is what we use in kind of our safe space network project, is a great way to have people control permissions and other things. You know, when a patient actually escalates a complaint in the system, they're confidential until they're not. And the decision of who takes away that confidentiality is always systems-based. You know, switching around the power to the patient that they get to expose themselves when they feel like there's enough value for them to, you know, carry themselves on within the system. That's really, really important when it comes to people actually having their concerns heard.
I really dream about an integrated health system in Canada. I do. I dream about it. And it's kind of, you know, what Alika was saying, you know, having so many different partnerships together and different people working together. I'm just thinking about, you know, how the federal government could not only work within the health system and with healthcare leaders, but with the patients, with Black, Indigenous people of color, with the disability community, with nonprofits who have been doing community health work already and have been filling the gaps that healthcare is not providing right now. I think about designers. I think about health literacy professionals. I think about translators. And I think about technology-driven companies who could help with building tools. I really think about how multiple sectors and different people should be coming together when we're looking at, you know, really harnessing what we have at our fingertips, but what we're not using together as a system, but also as a nation, and really sharing that power and sharing that decision making and listening to each other.
I love that so much, Melissa. I feel like you just designed the perfect advisory table. Just and could not agree with you more, that multitude of perspectives and experience and expertise, research, quantitative, qualitative, what we often refer to in lived experience as anecdotal information from patients, which actually is real data and real information to all of your points. And constructing that type of table, in my opinion, has been a gap. We talk about it, but we still haven't seen that level of diversity and perspective and inclusivity when we're looking at some of these challenging situations that we're facing across the system, not just technology and data and virtual care, but many other challenges that we're having across the system.
Julie, can I address
PJ? Yeah, please go.
I love and I respect each of these people's contributions. I'm not too shabby on a good day, but we've been doing this for a long time. When I hear such gospel truth coming out of each of your mouths, unfortunately, I'm reminded of the fact that I heard these same words from the last generation of patient advocates 5 or 6 years ago. I sat in the InfoA Patient Partnership Workshop 4 or 5 years ago. These words were said. I've talked to Ed Brown, Ontario telemedicine pioneer, who for 30 years has created the system we need, and at every step of the way has fallen short, not because of people's dreams, compassion, or dedication, because there's no rule to follow. There's no legislation. There's no incentivization for people to do better. Alika's so right. We need a reason. There are European countries that have legislation that hold them responsible to not only the GDP, but the country's happiness index. There are countries where your health budget as a doctor increases with the health and satisfaction reports, the patient-reported outcome, PROMs, of your patients. In Canada, there's none of this. Every single discussion we've had now, we will have in 5 more years, if patients don't activate and persuade that there has to be legislation. Because without a rule, these are all good heart, good, kind thoughts, which will amount to nothing in another 5 years. I'm sorry to be the dash of cold water, but I love these ideas, but there is still this glaring distance between them and reality.
I think it's an important closing reflection, PJ, and I'm going to invite others in the remaining few minutes that we have to add some closing reflections. And thank you for that, PJ. It's a real call to action. And I've been in this space for well over a decade and agree with you. Alika, some closing thoughts?
I think we've covered a lot of ground, and just like PJ has rightly said, these ideas aren't new, right? These ideas came from patients. These are not my thoughts and reflections. This is the aggregation of patient experiences that have been graciously shared over many, many years. If I could give advice to any of the patients who are on the line right now, remember and just acknowledge your lack of power, but also tell your provider, we don't recognize it. You ask for compassion, but instead of compassion, actually point out that you don't have control, because sometimes we make crass assumptions about your empowerment, and we sometimes take your frustration as empowerment, when in reality, it's really just frustration. So when you talk with your provider and you bring compassion into your care environment, just say exactly what you need. Ask for what you want for, and have some trust in your provider that will actually listen. And I'm pretty confident that the majority of us will.
Melissa?
Yeah, and just to go off of that, I mean, we've all been screaming into the abyss for a long time about all of the solutions we have, all of the issues that are going on, and discrimination is not new. Oppression is not new. And many of us have been dealing with that for our entire lives. And so we need to start listening to each other, and we need to think about accessibility, and we really need to come together on a larger scale. And I don't want to scream into the abyss anymore.
Laura and Dominik, a quick sentence from both of you.
So just grateful to have been part of this dialogue today. there's so much wisdom on this panel, and I hope we can continue to connect with everyone who joined this conversation, because actually it becomes a movement, right? When you do bring all of these individuals together in this type of setting and partnering patients with providers and administrators. I guess, we've been doing this for a long time, but I guess I have to feel hopeful, because otherwise it's just too tiring. So I'm seeing some nice energy and movement, and let's just do it, I guess. It's my comment. We can make it happen. So I think combined we can make some change.
And I'd say don't scream into the abyss. Vote. Email your hospital CEO. Tell your clinician. Right? There's this huge call to action that we need to have to actually move things forward, and that's the only way forward. I mean, the people who are involved right now can't be the only ones who are doing these action steps. It has to be everyone. It has to be a grassroots kind of overwhelming force to propel us into the next few years of what we actually want.
I want to thank all of you. Such an incredible conversation. I'm feeling slightly emotionally drained, but a good 90-minute talk, and appreciative of the audience and the listeners and the questions that they were posing and the reflections that they were making that we were able to weave into our conversation. And to all of you, Laura, Melissa, PJ, Dominik, and Alika, just so much appreciate your passion in this space, your perseverance, which is essential. Your persistence, and the patience that we're all showing, and let's just continue on elevating our voices, but also mentoring and coaching others to elevate their voices. So thank you, and thank you to AMS Healthcare for hosting this virtual conference. Take care, everyone.